model focuses on using innovative approaches to assist the equip-supported countries to rapidly scale up the new WHO policies like Test and Start, meaning that we are no longer waiting for the CD4 counts of our HIV-infected patients to drop before we start them on treatment. But everybody who's HIV infected must be initiated on treatment irrespective of the CD4 count. I work with a team of close to 250 people throughout the EQUIP consortium, and we are together making significant advances under the lead of USAID Washington, and we work side by side together with local USAID missions, the ministries of health in country, the local implementing partners who are currently funded by USAID for direct service delivery for HIV programs. EQUIP is a technical assistance model which focuses on 5 solutions which directly impact PEPFAR targets to expand treatment access. And the areas that we focus on are 1, the rapid test and start policy rollout support. The second one is differentiated models of ART service delivery, and we focus specifically on multi-month dispensing, either within facilities or at community level. The third one is strategies and technologies for a more efficient increase in HIV testing yield, initiating ART, retention on ART, and viral suppression, focusing on both children and adults. We also focus, number 4, on implementing treatment approaches that effectively respond to the needs of key populations. The critical thinking behind the focus areas is that in order to treat everybody who's HIV infected, health facilities are just not enough. And even if we do implement ways to fast-track patients within facilities, it will still not be sufficient. So facilities do need to be decongested, which means that countries need to move towards community-based HIV delivery models. And these could be community adherence groups or technology-assisted platforms for ART delivery, for example, the recently launched pharmacy ATMs. And we refer to these interventions as differentiated models of care. And in this particular examples, I have used a differentiated model of treatment distribution as an example. So once patients are no longer tested and treated at facility level, we want to make sure that the quality of care that they receive at community is not compromised purely because it's moved out of facility. One example is multi-month dispensing, and as it stands, most of our patients in the African continent currently receive 1 month's supply of medication at a time. And that means they have to come to the clinic every month to collect medication, which is not necessarily the most convenient way to do it for them. A good example is a truck driver who lives, for instance, in Lesotho and drives trucks to Zambia. So he has to go through South Africa, and he would be away from home for periods of 3 to 6 months. If we could find a way of supplying the truck driver with 3 to 6 months worth of medication at a time, it would increase the likelihood of his adherence and reduce the fact that he would default. So implementing this kind of policy also then frees up healthcare workers to be able to take care of the sicker patients who are more in need of care and allow stable patients to continue treatment on their own. We have learned the importance of integrating and linking patient data to pharmacy data to lab data and to use that information to improve patient management. We have formed partnerships with our laboratories, our pharmacists, our epidemiologists, our economists, and have created a national data warehouse that allows us to be able to monitor national program performance. This platform has also allowed the government to be able to monitor the HIV program at a country level, at a provincial level, district level, and also at a site level. And this means that we can send a manager at a clinic a report that says, these are the patients in your clinic that are not doing well and therefore need particular attention.